If you want to support Mary, I want to encourage you guys to go to twc.health/Mary. That is twc.health/Mary for all of your needs, whether it's an emergency kit, a contagion kit, ivermectin, or just a second opinion. They have everything that you need to take care of your health at twc.health/Mary. And every time you use the MARY promo code, you're going to get 10% off your entire order. Now, I also want to tell you guys about an amazing new product, Clear Skin Ivermectin Cream. Now, if you're like me, you might be experiencing or noticing redness and rosacea as you age. And you could cover it up with makeup if you're a girl. There's not much you can do if you're a guy, or you could just cure it. And the Wellness Company has an amazing product, the Clear Skin Ivermectin Cream. If you've tried everything for your cheek redness or rosacea and nothing worse, it might not be your fault. The real cause might be deeper than you think. So Clear Skin Ivermectin Cream from TWC is a prescription strength dermatologist developed formula that helps to reduce inflammation, balance bacteria, and restore your skin's natural glow. It's a triple action cream. It combines 3 medical grade ingredients for absolutely powerful results. Azelaic acid to unclog pores and fade dark spots, metronidazole to control bacterial imbalance and redness, and of course, the superstar ivermectin to calm irritation and eliminate skin parasites that contribute to rosacea and acne. So together, these ingredients work to reduce bumps, swelling, and redness while supporting smoother, healthier, and more radiant skin. And right now, you'll get $20 off if you use the promo code MARY at twc.health/Mary. That's twc.health/Mary. Promo code MARY to save $20 off plus free shipping as well.
Look, I've lost trust in the government and the DOJ, the Federal Reserve, you name it. They don't have our best interests at heart. We've seen inflation skyrocketing and national debt exploding, bank failures, never-ending wars, and don't get me started on what they did during COVID. I haven't forgotten. My savings, I protect them myself with real tangible assets, gold and silver. And that's why I have partnered with Goldco. They've helped thousands, including me personally. Gold's hit record highs, over $4,500 an ounce, and silver surging past $70. People are waking up. Get their free 2026 gold and silver kit today at drmarygold.com. And you can get 10% back in bonus gold and silver. We're here today with one of my good friends, Dr. Mollie James, who is a COVID warrior. She helped people. She was an ICU doctor during the pandemic, and she helped rescue people out of the hospital. I don't know anybody else that did what you did. And you actually managed to escape the wrath of the board. I know they went after you, but you were exonerated. And then now you're trying to get a license in Texas. But I think they don't like the fact that you testified on my behalf because they're giving you all sorts of trouble. What's going on with the Texas license?
Yeah, so I applied for a Texas medical license a year ago, November. So I have intention to move to Texas. I have personal reasons for relocating, and never ever has it taken more than 8 weeks, maybe 12 weeks to get a medical license. I have a very clean record. I've done a lot of jobs, so that's the hardest part of usually getting licenses. Every one of the jobs has to send a file on you. I have a lot of state licenses, so that's the main thing that ever slows down the process. Never in my wildest dreams would I have thought it would take 15 months and I still don't have a license. So the Texas Medical Board maybe should stop looking at your tweets and start checking their mailroom, because my references, Dr. Verone tweeted this, so I feel comfortable saying it. He sent a letter for me 3 times. I believe you had to send a letter 3 times because of their criteria and they couldn't find it. So it'd be really nice if we could get that pushed through. I have a clean record and there's no reason for that to get held up.
Yeah, it's very suspicious. And I discovered yesterday that 25% of physicians in Texas are trained in other countries.
And, oh, interesting.
Yeah. And then they just passed a law in Texas streamlining the licensing process for foreign trained doctors, because there's a shortage of doctors, but somehow they can't process your application. It's very odd.
Yeah. Yep. We've tried to cooperate with them. We followed up, you know, the routes between the time we have a question and the time we hear back is a 2 to 3 week delay. Generally they say your application's closed at 12 months. And basically I said, well, this is your delay. So as far as I know, my application isn't closed. However, it's just inexplicable delays. So at this point I'm suffering, you know, financial damages based on their ineptitude. So hopefully we can get that sorted out pretty soon.
Well, tell us, I know that you have some exciting new treatment for the vaccine injured, and that's why I brought you on today, because it's been very difficult to help these patients. It's a lot of trial and error, and it's, especially with the neurological issues, very difficult to treat. And we're, you know, left to figure out things on our own because the government is not helping us. So tell us what you have been doing and have had success with.
Yeah, so one of the things I brought into my practice at the end of 2025 was it's a mitoregen therapy, so mitochondrial regeneration. Basically, the layman's way of thinking about that is there's a signal, there's a microscopic oscillation of insulin that is sent to the liver from the pancreas. Studies date back in the 1970s. They put catheters in and figured this out. There's a tiny signal of insulin going to the liver that the liver then releases enzymes that support the mitochondria. So throughout illness, we lose this signal. So the mitochondria stop using glucose as a source of fuel and basically lose their efficiency. So a very brilliant engineer figured out how to replicate this oscillation through an external pump. So we can now replicate that signal IV. It's a 3-hour infusion in my office. It's just a tiny amount of regular insulin. And over the last 30 years, they've repeatedly studied and published on this, and it increases ATP production by 30%. Wow. So yeah. We eat food and our mitochondria turn food into ATP, which is kind of our Duracell battery. It's our unit of energy. And so increasing ATP production by 30% has wonderful implications for people.
Well, and does it last? Is it you know, you do this infusion and then how long do people feel immediately better? And
yeah, it's kind of across the board. So it depends on what we're treating them for, what their condition is, and what they're trying to get out of it. So they've repeatedly published that neuropathies, after 12 treatments, 90 to 95% resolved.
Really?
Wow. And I've had, so if anyone out there is suffering from neuropathy, you don't have to. The medications just mask it. It is an energy production problem. I've had a patient, she's actually on my team, has chemo-induced neuropathy. And within an hour of starting the treatment in our chair, the burning sensation went away.
Wow. Wow.
So this is truly profound. It has implications, you know, to me, the mitochondria is the root of the root problem. And so I explain it like this. If you're tired, if you're exhausted, you're not going to be cleaning your house. You're not going to be doing home maintenance and repairing your roof. Our cells do the same thing. So if they're exhausted and not making enough energy, they're in survival mode day to day, and they're not running their higher order operations. So if we can get them that extra energy, now they're just like we do. They're going to wake up. They're going to start cleaning out the cell. They're going to start doing their processing, their detox. And we have an inherent program in our DNA to repair. Our cells know what to do if they have the right energy. So basically, we give them the power to do their own healing.
Wow. And so it's an IV that lasts for 3 hours, and you're giving tiny amounts of insulin during the IV. Do you give them glucose too, or how do you prevent their?
Yeah, that's actually one of the hardest parts of the treatment. So we're literally talking about 5 cc's over 3 hours. That equates to anywhere from 10 to 15 units of insulin, maybe total. So a very small amount given every 6 minutes as a pulsation. The hardest part for people is my patients are usually eating low carb or carnivore, keto. You know, they're avoiding processed sugars. So when we're doing this, they actually have to carb load. And so we check their blood sugars every 15 minutes because as we wake up the mitochondria and now they're using glucose for fuel, it drops people's blood sugar. So we want to make sure as we wake those mitochondria up, we can feed them and they have energy to use so they can keep making energy.
Interesting. And then how, if they do multiple treatments, how far apart are the treatments?
It depends on, again, what we're treating them for. So the people I trained with had a patient that literally had a terrible wound on the foot and was trying to avoid amputation. That patient was treated every day for 4 months, I believe. So 80 treatments back to back. In our office, that's not usually feasible. So if somebody's really sick, we're looking at 2 or 3 times the first week. And then we may titrate that off to once a week and then eventually once or twice a month for maintenance if they have a chronic process we're trying to keep reversed.
Right. And then have you had luck with the vaccine injured patients?
I don't know that we have as many of those patients. You know as well as I do, they've been victimized so many times that by the time we get to something that actually can work for them, they're out of money and they're out of hope and they're out of trust in the medical world. So, again, to come out now 5 years later and say, I have the solution for this, there aren't a lot of people who have faith in that. So definitely I'd love to bring this to the vaccine injured because we know that the spike protein was a direct mitochondrial toxin and it should work pretty well for this.
Right.
Yeah.
You have multiple offices now. Where can people find you?
Yes. So our main office is in St. Louis in the Chesterfield Valley. We have a small office in my hometown in Sheraton, Iowa, and we are opening in the Des Moines market in Q1. So later this year, in just a couple months, we will be open in the Des Moines market.
And then I think you were talking about Texas as well, right? If they'll ever give you a license.
If they'll give me a license, I have a couple other things that now need to fall into place, but we're really excited to open in Texas as well. We have sites on Tyler, Texas, and or the Hill Country. So, hopefully very soon we'll be in that market too.
Right. And I know you used to be you were a general surgeon and then critical care. And now you're doing a whole different model. Can you tell everybody what your practice model is?
Yeah, for sure. So James Clinic was born out of COVID. As you alluded to, I got fired during the middle of COVID, right at the beginning of the Delta wave, because I wouldn't take the COVID shot, and that just became non-tenable. And also they were removing treatments from the ICU. So I had to look people in the face and say, I'm intubating you and I'll do my very best, knowing I didn't have the very best available. So I just couldn't ethically do that. So James Clinic was born out of that. Now we are a concierge model. So the very best care that we get is having patients join our clinic. We follow up with them every month to make sure their health stays on track. We're staying consistent. That's really a lot of people can give a prescription, but having that consistent support is really essential. And then troubleshooting the plan, right? Sometimes something will work for a while and quit working and we have to pivot and as things evolve. So the concierge model is really what we're focused on. We actually brought in a line of state-of-the-art testing as well. This mitochondrial therapy is so powerful that it's going to reverse illness. There's multiple studies where it's reversed dementia, it's helped stroke patients regain function, reversing fatty liver, reversing cirrhosis. So I brought in a whole line of testing that patients can do, functional testing. We can look at the blood vessels, we can look at the heart, we can look at the liver and know where we started and then have objective solutions for where we go with that.
That's wonderful. And do you do telemedicine? Can people from out of state consult with you?
We do a lot of telemedicine. We have patients all over the country. We recommend that they come to our office for that first initial visit, especially now that we have the functional testing. One of the things we have is really cool, and I definitely think it will help the vaccine injured, is the glycocheck. So one of the things that's been missing from the discussion is the glycocalyx. That's the lining of our arteries that look like little eyelashes or little seagrass. COVID actually mowed that down. So when you look at how that protects the inside lining of the arteries, without that, this is why people had heart attacks, strokes, blood clots. So we can actually measure that by putting a little microscopic camera under the tongue. We can get a health score of the mitochondria. It's very cool. You can look at your own capillaries and single red blood cells flowing through your capillaries. And we have a supplement called Revasca from the same company. We can actually rebuild that using a seaweed-based supplement. And, it helps regulate blood pressure and just repair basically circulation to all the organs of the body. So putting all of this together, I do think there's hope for people who are pretty injured.
That's very cool. Now, what's the name of that supplement again?
It's called Revasca,
Mm-hmm.
and the testing is called GlycoCheck. So coming up with the IMA, I believe we're going to have a webinar with the two professors that developed both the testing and the treatment and talk about this. They actually had these little cameras in the ICUs when COVID hit. They were studying it in critically ill patients. So they have exact timeline data of COVID patients and have stratified who didn't survive the ICU based on the health of their glycocalyx. So they have a lot of really good data that supports that.
Wow, that's very, very interesting. So tell everybody where to find you. Is it Dr. James Clinic, or what's your website?
Yeah, jamesclinic.com. So jamesclinic.com. If you haven't been on it in a while, we've totally rebuilt the website. So there's a ton of information there about what we do, how we do it. We're always hiring. So if you want to join our team, there's a careers page. See if it resonates with you. We want our people because we move at a very fast pace and it's not for everybody. But yeah, we're growing quickly. And again, a lot of information on there about what we do and how we do it.
Well, wonderful. This is promising. I don't know if you've been following, but we've been looking at filtration, and I know you were doing EBU. Are you still doing EBU?
We do, yeah.
Yeah, and this one though is in Japan. It has a special filter, and they're using stem cell growth factors. Tell us about your process with EBU.
Yeah, so EBU, it stands for extracorporeal blood oxygenation and ozonation. So basically, it looks a lot like dialysis, if anyone's familiar with that. So we put an IV in both arms. The blood pumps out through a small, slow pump. It's a little freaky to see your own blood outside your body at first, I will say that. But it goes through a dialysis filter. So it is not dialysis. It doesn't have a diacylate in it, but it's the actual filter. So we know that things get hung up in the filter. The blood is then exposed to oxygen, ozone. We run it through UV light and colored light. So we get the photodynamic therapy, and then it circulates back to the patient. And we run that circuit for about an hour. It treats about 2 to 3 liters of blood, or half of the blood. So you get 4 treatments in one. You get the filtration to pull out inflammatory cytokines. We think it pulls the spike protein, potentially biofilms, mycotoxins, cellular debris. Then we get the oxygen exposure. So we get those red blood cells to separate and pick up oxygen and carry that. There's ozone, which helps buffer the antioxidant system in the body. So it helps with that out of control inflammation, the reactive oxygen species. And then the light therapy stimulates the mitochondria, stimulates the immune system to take care of any latent infections and things. So it's a wonderful treatment. Truly, after I did that, it's the best I've felt in a really long time.
And what you do, hyperbaric oxygen as well?
We do. We have the soft hyperbaric chambers. Patients really like that because they can sit up instead of laying in those tubes that you've seen. We use that specifically. I like it for patients with neurologic issues. I like it for patients who have specific wound issues as well. There's so many different versions of like vaccine injury that it doesn't help all of them. So I've had patients with the cardiac issues who've done like 40 treatments and it didn't help. Well, we're not seeing that it would have. So we try to be really selective with that.
Yeah. And are you doing, the big push now is stem cells and peptides? Are you dabbling in that at all?
Yeah, we've always done PRP. So before we had the mito regen therapy, PRP was great for neuropathy, and it still is. It definitely helps those patients. I think there's a lot of people who had latent Lyme infections and dormant infections that once we had the immunosuppression from either COVID or the vaccine, these infections came to the surface. So for those patients who are kind of blown off and disregarded, we actually diagnose those. And then when we do PRP, it comes in and kind of resets the immune system in a way, so that your body's not looking at these infections just saying, oh, it's supposed to be here. It actually starts to fight those and do something and help with the inflammation. So PRP, we're definitely doing. We have some peptides that we've incorporated as well. And then we're building out an entire mito regen support process between infusions that includes, supplements that support our foundational supplement, CoQ10, red light therapy, just additional things we can do to help patients, progress out of where they seem to be stuck.
So is CoQ10 a big supplement for mitochondrial support?
It is. So if you look at the electron transport chain, I think of this as a series of water turbines, and we have to like push the electrons down the water turbines to kick out energy at the end. So there's 4 to 5 proteins in that water turbine, and CoQ10 helps push that forward at certain places. So definitely good for mitochondrial support. L-carnitine is another one that's good. And then working on detox. If you start your car in the garage, all that dirty air is going to be stuck in your garage. So we need to air that out. We need to make sure that the lymphatics are moving. So when the cell does rev up its energy, now we can exchange nutrients in, garbage out, and keep the whole system supported. So I think this is where so many things fall short. Is there just one, do this and you'll get better? No, you have to kind of do it all the way down the line. So you have all the support. Once you fire up one mechanism, you've got to support that down the line.
So what do you recommend to patients in terms of detox, of getting the garbage out?
Yeah. Sleeping well, make sure to track your sleep. Make sure if you're not optimized, get rid of the blue light, get the red light. Our friend, Dr. Jack Cruz, has a lot on light and electromagnetic fields. So, when you wake up in the morning, get sunlight, put your feet in the grass, get your charges correct. Start with that. Drink plenty of water. Make sure your diet is as clean as possible as you can afford to do. Move your body throughout the day. Sweat, infrared sauna. Vibration plates are big. Rebounders, things like that. Get your body moving a little bit. And make sure you're having BMs every day, right? Literally getting all the stuff out is important. And there's so many people who are stagnant, and the more you're stagnant, the more you're stuck. So looking at it from that perspective.
Yeah, it is. When you really pin down how much you sit and lie during the day, it's pretty bad. You don't realize it until I went skiing last week, and I'm like, gosh, I'm never on my feet for 4 hours straight like this. Usually if I'm lucky, 20 minutes in the gym, and the rest of the day you're sitting basically. I don't think people realize that. And yeah, sleep is huge. So for people that struggle with sleep, what recommendations do you have?
Yeah, so one of the things I did a kind of a deep dive into is, again, the blue blocker glasses and settings on your phone and your devices if you're using those late at night to shut off that blue light. Switching your LED lights back to incandescent bulbs. They have special night lights for your room that are red or amber light. So setting your environment, number one. A lot of people don't sleep well because their blood sugar crashes in the middle of the night. So we pick that up with continuous glucose monitors. So don't eat a heavy carb load before you go to bed, because patients don't always wake totally up, but it disrupts their deep sleep. I like trackers. I like to know what my sleep score is in the morning. So, if that's anything you're interested in. And then if we're just really not making progress, hormone optimization is great, especially for women, as they hit that point in life where menopause and hormones are causing a problem. And then there's a great sleep peptide, DSIP, that we've incorporated as well. Very good luck with that. We use a lot of melatonin in our practice as well. So kind of that, we just work everybody down, start at the basics and work our way up.
Well, let's talk about that peptide. I haven't heard of that. Is that an injection?
It is an injection. I believe it stands for Delta Sleep-Inducing Peptide. So what that does, again, just kind of helps set the mood, calm things down, get you into that delta wave so you can sleep. I do it as a short-term injection because usually if we can get the sleep cycle reset for people, they're good to go from there. So I think our vial is like 20 days, 40 days. So I have them do one round of it and then go off of it and see where they are. But we're definitely trying to pull them off of prescriptions. Patients who are drinking alcohol or on benzodiazepines, those are disrupting that restorative sleep. So we really want to get off of those. We have some neuro devices too that are really cool. We have something called the Brain Tap. It's a take on binaural beats. So it's actually a headset with an eye visor, and it's a guided meditation that basically helps patients get into the right brain waves to promote sleep. So there's a lot of things you can do that are non-prescription that actually may be much more impactful.
Yeah, I will say my big trick is I listen to a boring audiobook or I listen to a podcast and it distracts me, because you lay down and the first thing you do is start going over all the problems you have or things you need to do. It's like the first time you have a moment, right, to really contemplate. So my big trick is to listen to somebody else talking to get my mind off of my own issues. And I mean, that works 90% of the time. And I also think the hormones, the progesterone, if you are in menopause, that's huge. Do you do a lot of hormone replacement therapy?
We do. Yep. Again, there's two ways to look at it. There's these hormone replacement clinics where that's all they do. I feel like that's a part of what we do as an integrative clinic, right? We bring all of this in and sub-select. So, some of our patients don't want to do hormones. And so we have lots of different options for those patients, but it is a key of what we do and help patients when it's the right thing. So, yeah.
That sounds like a common sense approach, which we definitely need more of. Anything else that y'all are offering that we haven't talked about that might be interesting?
Yeah, the state-of-the-art testing, I'm just so excited about that because that paired with the mitochondrial regen, now patients, whether you're sick and trying to get better or you're good and you're trying to be a performance athlete, it's kind of the same hill. It's just where are you starting on it? We have the max VO2 testing, so you can run on the treadmill and get a lot of information about how effectively can your body start to make energy from oxygen and food and make that ATP. We can measure that. And then as we do these treatments like the mito support, the mito regen, getting your sleep, we can actually track your progress and give you objective data points. So not only do we have to help people, but we have to show them how we're helping them. And I love that. Yeah. It's fun.
Well, that's exciting. I'm going to come visit you and get the tune up.
Yeah, come on up.
Well, thanks so much, Mollie. Great to see you again. And we'll have you back soon and get some updates.
Okay, sounds good. Thanks for having me.
Look, I've lost trust in the government and the DOJ, the Federal Reserve, you name it. They don't have our best interests at heart. We've seen inflation skyrocketing and national debt exploding, bank failures, never-ending wars, and don't get me started on what they did during COVID. I haven't forgotten. My savings, I protect them myself with real tangible assets, gold and silver. And that's why I have partnered with Goldco. They've helped thousands, including me personally. Gold's hit record highs, over $4,500 an ounce, and silver surging past $70. People are waking up. Get their free 2026 gold and silver kit today at drmarygold.com. And you can get 10% back in bonus gold and silver. And I am joined with Dr. Alejandro Diaz, who is a pediatrician and is going to bring us up to date on a very interesting story out of San Francisco. There is an outbreak of tuberculosis, and tuberculosis, we think of tuberculosis as affecting people in low-income areas, in prisons, people that are immunocompromised. It is very odd to have an outbreak in a wealthy part of San Francisco in a high school. Am I right?
Yes, Dr. Bonin, thank you so much for having me back on your show. And that is true. It is true. Tuberculosis, specifically pulmonary tuberculosis, has been a disease for centuries. I want to say for the last 9,000 years in the books of medical history. And it has been one of the most, if not the most deadliest communicable diseases in the world for centuries. And it's very, very rare to see it in upscale societies or upscale areas of certain cities. So it's really interesting why at this high school in San Francisco, which is, I believe it's a high school, it's a Catholic high school, and they found 3 active cases of pulmonary tuberculosis and 50 what we call LTBI. LTBI means latent tuberculosis infection. And we can break those down, and we can talk about the pathophysiology of tuberculosis, where it's more prevalent, where is the incidence in the United States and worldwide. It's a very interesting topic.
Yeah, it really hasn't been on my radar as a doctor in quite some time, not really since my training, because I don't think I've seen a case since residency. So tell us a little bit about tuberculosis.
So you're going to be very surprised, Dr. Bowden, with what I am about to share with you. So there are two ways. There are two main ways to diagnose tuberculosis. One, which is the most common way to diagnose tuberculosis. That's how we learn in medical school, in residency training, and so on and so forth, which is passively. What I mean by passively is that you are at your office, at the ER, or you are at the hospital setting, and you receive a patient that has been coughing for 3 weeks, has been having night sweats, losing weight, fatigue, malaise, and they don't feel well. So there is when you can suspect potentially tuberculosis, obviously with a good medical history and so on and so forth. The other aspect, which is the most complicated and very, very few people do this, is when you look for tuberculosis actively. And let me break this down for you a little bit and for the audience to understand this interesting and fascinating part. In the United States, there are 1 million legal immigrants coming each year. 600,000 of them, they are screened for tuberculosis, STDs, and many other diseases among mental health problems. Within the United States, how do they arrive here? They arrive to the United States legally, authorized through a various categories of visas, mainly 8 categories with subcategories. Combine all of them, we're talking about potentially 100 different categories that people can seek for a green card in the United States. Those 600,000 immigrants that they have to be screened within the United States, once they have been here for 1, 2, 3, 4 years, they have to go and see what we call a civil surgeon. Who is a civil surgeon? A civil surgeon has been appointed by the United States USCIS, which is a government entity. They appointed civil surgeons. There are approximately 6,000 civil surgeons throughout the 50 states of the United States. The applicants, they go to see the civil surgeon, they check their immune status, they check their potentially tuberculosis status, mostly LTBI, which is latent tuberculosis infection, and STDs. So they do their exams, they do the tests. The other component of the 400,000 remaining applicants, they are screened overseas, and they are screened by doctors that they are called panel physicians. These are accredited, licensed, and recognized physicians in their own countries. Imagine, Dr. Bowen, these 760 panel physicians, they are distributed all over the world. They are appointed by the CDC, the local U.S. consulate, or the U.S. embassy in different countries. So how it works is that the applicant who has been able to apply for a green card, they go to see one of these panel physicians throughout the world, and they do exactly the same screening as the civil surgeons once the applicant is here on different visas, but overseas. But it's much more accurate, I want to say. Why? Because they take, if the applicant is 18 years or older, they take a chest X-ray.
Mhm.
If there is any indication by the competent radiologist that there is something that we have to screen for additional testing, we do that. And then they go and they take what we call an IGRA test, which is an interferon gamma release assay. That is to understand if the patient has or doesn't have LTBI, which is latent tuberculosis infection. If the TST or the interferon gamma release assay, the IGRA test, is positive, then the patient, they have to collect sputum collections to send them to the lab and do culture. If the culture is positive, now we understand that that patient, he or she, they have pulmonary active tuberculosis. Here's the tricky part. This is why I say active versus passive. Passive, the patient will go and see you and they will tell you, doctor, I'm sweating. Every night I'm sweating. I'm losing weight. I'm coughing. I've been coughing up blood, hemoptysis, and I don't feel well. I'm losing weight. Probably your average second-year medical student will know that we have to rule out tuberculosis.
Mhm.
That's the easy part. The difficult part on the immigration standpoint with this 1 million newcomers to the United States is that they will deny every single symptom. Why?
Oh,
Because they
right.
want to immigrate.
Right.
So it's when it gets very tricky. That's why you need highly trained, highly qualified physicians that they are experts at diagnosing tuberculosis. So a good screening specifically of active pulmonary tuberculosis overseas with this 400,000 applicants a year, screened by 760 panel physicians throughout the world, that will be the gatekeepers for the United States to have a low burden of active tuberculosis cases in the United States, whereas the civil surgeons, as we understand that they already know that they don't have active tuberculosis, but they potentially can have latent tuberculosis infection that also needs treatment. So that is the part when it comes to immigration.
So why don't the doctors in the US do what the doctors overseas are doing?
Interesting question. No one knows. No one
Cost?
knows. Well, no, it's pretty much the same cost. We're talking about an average ticket for each individual who is going to screening either with the civil surgeon or the panel physician, $450, and that includes everything.
Mhm.
That includes test, physical examination, and some lab work. But no one knows. No one knows why exactly they don't do that. And the interesting part is that these applicants here within the United States, they have been living here for 1, 2, or 3 years. If they have had active tuberculosis, they will infect, many people. So
Will the US deport them if they're caught with tuberculosis?
no, once they're here, they go to see the civil surgeon, and the civil surgeon can diagnose active pulmonary. They will treat them, and they will send them to the local public health office.
Right.
It is very interesting how it works. So the reason that I'm mentioning this, number one, it's to educate our audience, and virtually not many people know about these programs.
Right.
But they're actively, can you imagine screening 1 million people a year? That's a lot. That's a heavy burden of screening. And But it's interesting how it works. And if you take a look at the states that have the largest burden of tuberculosis, those are they have the highest rate of immigration to their states. Like, for example, in the last couple of years, the state of Kansas, the state of Utah, and the state of Maine, they haven't had the largest increase in tuberculosis cases. Like in the case of Kansas, they have had an increase of 150%. That's an immense amount of numbers. 50% for Utah and 50% of cases in the state of Maine. Why? Well, they started to receive a lot of refugees, a lot of asylees and asylum seekers, and more immigrants are coming to these states. And we have to understand another thing. And to be honest, I talk about this at the beginning of the COVID operation as an immunologist, because I said, after the rollout of the so-called COVID vaccines that you and I know, they are just toxic injectable products of experimentation, and they really mess with the immune system. So I said, we will start to see a rise on tuberculosis cases and other communicable diseases because our surveillance systems of T cells, CD4, CD8s, interferon gammas, interleukins, cytokines, and so on and so forth, they're going to be weakened. They're not going to have enough potency and ability to defend for communicable diseases. And hence, look what's going on right now.
Right. And tell everybody how difficult it is to treat tuberculosis.
It is. That's a very good question, Dr. Bowden. So tuberculosis also, once you understand the problem and you are in this world of tuberculosis, you know that you have your drug susceptible, pan susceptible cases, which are the easy one to treat, that they will respond to the 4 common drugs that we use for the last 45, 50 years. And then you have your moderate resistant tuberculosis bugs, the mycobacteria tuberculosis, which is the bacilli. They can get resistance for different reasons. And then you have to change those 4 basic drugs and combine with the other medications. And then the hardest part, which I treat some of them, are what we call XDR, extreme drug resistance. You don't want to get those cases. Those are very difficult to treat. Those are very serious, but because they can spread that extreme resistant bugs, and you can have worse than any COVID operation, pandemic, or anything else. So it's easy, kind of easy, when you get a multi-sensitive drug bug, which is, thank God, the most common, but it gets more tricky when you get more resistant bugs.
What are you seeing tuberculosis in seemingly healthy people now, or who is your typical tuberculosis patient?
Well, in my world, because I used to be a panel physician for many years, it was obviously the immigration population.
Mm-hmm.
Let's say, like, for example, in Mexico, the rate, and when we talk about rate in public health, we talk about a case per 100,000 population. So in Mexico, roughly was between 18 and 22 back in the day. Mm-hmm. But we were able to find up to 50, 55 per 100,000. Why? Because we were actively looking for pulmonary tuberculosis, whereas the rest of our colleagues, they're not looking actively for tuberculosis. They're waiting for patients to have the full-blown cases with signs and symptoms, and then they can diagnose because they can suspect. So in my world, my typical patient was the immigrant. And as you know, Dr. Bowden, the largest and the country that sends more immigrants for obvious reasons, legal immigrants and illegal immigrants for obvious reasons to the United States, it's Mexico, followed by China, and then India, the Philippines, El Salvador, Cuba, and so on and so forth, Vietnam, and so on. So it's important to understand demographics, to understand public health, to understand a little bit about politics, to be a panel physician, because you are dealing with all these problems, and you have to be ready to diagnose, number one, and then to treat properly. Once you treat the patient, now they will be, and they're completely tuberculosis free. Now they can migrate to the United States. When the screening was overseas, when it's within the United States through the civil surgeon program, which is USCIS appointed doctors, that's a different story. But most of the time, they just see LTBI, which is latent tuberculosis infection. How interesting is all this?
No, so why is tuberculosis more of a problem in these other countries? Is it because they don't have the right surveillance and they're not getting treated properly, or what is the issue there?
Well, the study of tuberculosis, Dr. Bowden, it's very interesting and it's fascinating. So, like I said, it's been around for approximately 9,000 years. And it has killed more people than all viruses, bacteria, parasites, and wars in the history of mankind combined.
Wow.
So it's a terrible disease, and it's important to know. That's tuberculosis 101. The reason for, like, let's say we're talking, like, for example, in the United States, the rate is 3 per 100,000 population. So per every 100,000 people in the United States, you will see 3 cases. But back in the day was lower. We starting to see a rise in tuberculosis that we haven't seen in decades, specifically after the COVID operation. And I kind of predicted this 4 or 5 years ago. But let's see the incidence of the Philippines. The Philippines, they have approximately 600 per 100,000. Nepal, 550 per 100,000. And, Mongolia, 400 and something. And then India, 199 per 100,000. So it really has to do with public health, sanitary conditions, the quality of water, the quality of air, different things that it comes into account to the epidemiology of tuberculosis. Very interesting.
Yeah, probably close living conditions too, I would imagine.
Oh yeah, yeah, definitely.
It can spread pretty easily, right? Talk about how contagious is it?
It is very contagious, and the difficult or the toughest part about tuberculosis, it's that it's airborne disease. So somebody's coughing up flush drops, or is singing, or it's even talking loud. You can spread tuberculosis if you have. It's very important to understand this part. Somebody who has active pulmonary tuberculosis can definitely infect through these routes somebody else, and it's highly contagious. If somebody has latent tuberculosis infection, they cannot spread the mycobacteria. That will be within your lungs, and it will be through very and sophisticated immune processes. They will be contained in a specific granuloma, and it will be there. But LTBI is just waiting for your immune system to go down, to have a dent, or let's say a weakened immune system, and it can activate. This is why it's so important to understand the pathophysiology and the immunology of tuberculosis. So basically, Dr. Bowen, how it works is that somebody gets infected with the bacilli, it get into the airways. The alveolar macrophages will come and phagocyte, engulf the mycobacteria, and then we'll send it to the dendritic cells, which are the antigen-presenting cells. Those in combination will take it to the nearest lymph node. That will activate T cells through CD4, specifically naive CD4, and that will activate Th1, which will activate interferon gamma, interleukin-2, tumor necrosis factor. That in combination with other helpers like CD8 and so on and so forth will mitigate the infection and will create the granuloma, and it will stay here, and the patient will not develop active pulmonary tuberculosis. But if for some reason those different steps of the immune cascade does not work, we will convert that into active case, and we can spread that mycobacteria to others.
Do you have to treat the latent form of the disease, or do you just watch that?
No, you have to treat it. Once you diagnose that, you have to treat it for 3 to 6 months. It really depends on the protocol, and it really depends on the patient. Not all patients are equal.
Yeah, I think everybody needs to realize when you get tuberculosis, you are being treated for months. It's not a 1 week prescription with an antibiotic. It is a very long treatment usually with multiple medications. One thing I was going to mention with this, and now I've just completely lost my train of thought. For the average person that is just, worried that maybe they've been exposed. They don't have necessarily symptoms, but if they want to get tested, what should they do?
Well, they should go, and first we have to understand who can develop tuberculosis. So let's say somebody in the United States that travels frequently to high burden countries, like the one that I mentioned, like Afghanistan. Well, not many people will go to Afghanistan, but like India, the Philippines, Mongolia, all those countries, specifically in Central Asia, Southeast Asia, and many others. I mean, the list goes on and on. But if they go to even Central Africa, a lot of tuberculosis. But if they go and travel for different reasons, either for leisure or business or whatever, I definitely recommend them to every now and then go to their primary care physician to get tested for LTBI, which is the most common LTBI. And but if somebody gets the symptoms, which I'm going to repeat it, it's fever, coughing for at least 3 weeks, sometimes coughing up blood, losing weight, night sweats, malaise, the patient doesn't feel well, they don't have appetite. Most likely, the chances are that it will be a diagnosis of tuberculosis, but there are other diseases that they can mimic tuberculosis. So it's tricky.
Yeah. So, I mean, when I was in residency, all we did was the PPD, which is a little skin test. But you mentioned, is a chest x-ray necessary? You said the EGAR test, is that necessary as well to completely rule it out?
The problem with the PPD is that it's extremely unspecific, very unspecific. So I prefer the EGAR, which is the interferon gamma release assay, which is just a blood test. And if that is positive, that means that the patient most likely has been exposed to the mycobacteria and they have LTBI. Obviously, always a chest X-ray and so on and so forth, so the doctor can make the decision to start treatment. So treatment for LTBI, it's roughly three months. For active TB, which is pan susceptible, I want to say 6 months for, medium resistant. That will be probably 8 months to a year. And XDR, it can take up to 2 to 3 years to treat them. And it's extremely expensive because you also need to get injectable antibiotics.
Yeah, one other thing I was going to mention, a trend that I've seen since the pandemic is people are taking steroids more and more. And steroids definitely have a role in respiratory disease, but people don't realize that when you take steroids, when you take a Medrol dose pack or you get a steroid shot, it lowers your immune system. And that may be another contributing factor. I don't know if you're seeing this as well, but I'm seeing patients who they go to urgent care and the doctor puts them on a Medrol dose pack at the start of their illness, which is not the way it's usually handled. Usually you use the steroids towards the end of something when it just won't go away and patient has other things going on. And during the pandemic, yes, they played a vital role, but now it's become very routine to give out steroids. And I just wonder, could that also be leading to a rise in tuberculosis? Or does it take more than just steroids, you think?
That is a great point. And you're right. You're right. Definitely high and frequent doses of steroids, definitely, since it's an immunosuppressing medication, definitely can lead somebody to develop from LTBI to active tuberculosis. So basically, Dr. Bowden, any circumstance or any situation that weakens the immune system will lead to somebody who has LTBI to develop active case of pulmonary tuberculosis. And my fear is that we're talking about 5.5 billion people took those jabs, those toxic injectable products, so-called COVID vaccines. We're talking about huge amount of people that their immune system has been weakened. And I'm anticipating to start seeing a rise in cases of pulmonary tuberculosis, which is that's a bug that no one wants to mess with that. That's a real bug. COVID, it was a walk in the park.
Right.
TB, that's a different story.
Yeah, I'm so glad we're talking about this because, like I said, tuberculosis, I really haven't thought about it since residency. And that's unless you're working in certain environments, as a physician, it's just not on your radar, but it certainly should be. And while we're talking about immune system suppression, we should probably touch on cancer. And February is Cancer Awareness Month. I saw a patient with a brain tumor last week, and it was a reminder of, what's going on. And have you been seeing a rise in cancer in your own patients? And do you think that that's also related to the COVID shots?
I have seen like never before in my career. I've been a physician for over 35 years, and I haven't seen this incredible amount of cases of cancer, from glioblastomas, lymphomas, breast cancer, colon cancer, pulmonary cancer, renal cancer, you name it, leukemias, and so on and so forth. And I really think, because I've been doing a lot of research, and I ask all of my patients and all of the people who call me. I do a lot of telehealth, and I consult people virtually from all over the world. And the vast, if not all, majority of cases with cancer, they have been vaccinated.
Mm-hmm. Right.
We also, as an immunologist, Dr. Bowden, I can tell you that anybody who took the jab, the COVID jab, we can kind of determine that person has a secondary immune deficiency by definition.
Right. Do you think people should be more aggressive about screening for cancer? And if so, what should the average person be doing?
Wow, that's a wonderful, tough, difficult question, and very difficult to answer because I don't I never want to be part of the system that create mass formation, that creates hysteria, and that everybody's gonna have to be worried and have to be preoccupied that if they're gonna develop cancer. Just change your habits, eat better, real food, uh, go out to do outdoors activities, get on enough sunlight, take your supplements, sleep well, have positive thoughts, and just, if you're a believer like myself, you know, increase your faith, your belief system, go to church. Things along that line definitely will help to live longer and better. I just came back from India. I was a speaker at the YPO, amazing YPO conference summit of vitality and longevity. And it's incredible, Dr. Bowden, how regardless of where in the world, everybody after the insanity and the hysteria of the COVID operation, everybody's is trying to taking care of themselves more than before. Now everybody's thinking about longevity, vitality, living longer, living healthier, living better, and they're drinking less. They're virtually, I don't see more people. I mean, people smoking anymore that much as like when you and I were growing up. It's, there are some social trends that they're changing in a good way. So in terms of being preoccupied for that, just change your lifestyle, and I guarantee that people will feel better.
What about supplements? Are you a proponent for everybody, or what if anybody's going to take one or two supplements to boost their immune system, what would you recommend?
Great question again. I recommend supplements for everybody. Supplements for everybody. Zinc, vitamin C, and all these natural products like obviously your vitamins. It's very important. Glutathione. I mean, go and get every now and then your IVs that you can.
I love glutathione. Yeah.
I love it. It's one of the best products. And just try to decrease oxidation, just try to decrease inflammation. And like the Greeks used to say, your food is your medicine.
Right. Yeah, agree. Well, thank you so much, Dr. Diaz, for joining us again. It was a very interesting topic, and we'll have you back soon.
Thank you so much for having me back.